नमो भगवते वासुदेवाय धन्वन्तरे अमृतकलशहस्ताय सर्वामय विनाशनाय त्रैलोक्यनाथाय श्रीमहाविष्णवे नमः.
Good evening, everyone. We welcome each and every one of you. Before moving on to the session, let's welcome our eminent faculty, Dr. Rahul R. Nair. He took his BAMS from Vaidyanathan P.S. Warrior Ayurveda College, Kottakkal, and MD in Yoga Nidanam from Pariyaram Government Ayurveda College, Kannur. Currently working as Assistant Professor and Head, Department of Yoga Nidanam and Vigruti Vijnanam, Specialist Consultant at Teaching Hospital, Ashtangam Ayurveda Chikitsalayam, Palakkad. Senior Visiting Specialist, Sidaram Pharma Specialty Clinics, Palakkad, and Medilife Polyclinic, Kutanad. Worked as tutor in Department of Kriya Shariram, Amuda School of Ayurveda, Assistant Professor and Consultant, MVR Ayurveda Medical College, Kannur, Evaluator and Examiner for University of Kannur and Kerala University of Health Sciences Graduate Examinations. He tries to explore the vast potential of Ayurveda in providing solutions for spectrum diseases like cancer, autoimmunity, pulmonary and cardiac disorders. We honorably invite you, sir. The dais is yours.
Vada kapha pradhana sannipada avastha. And also, if there is intolerable pitta, you have to introduce Varna Muktadi Gulika. So, in that way, different varieties of new medicines, new procedures, you are keeping talam in the form of Rasnadi Churnam or Kachuradi Guliga when the disease turns fatal. So every other mechanism is brought into action to prevent the fatality. So this type of interventions we have now demonstrated in advanced COVID cases throughout India. I got a chance to interact with the different physicians, especially in North India, who have practiced with the Jayamangala Rasa or Sukshma Trifala, Mahalakshmi Vilasa Rasa, Pradyabalangeshwaram, Ananda Bhairava Rasa, Godandi Bhasmam, Vasanta Kusumagaram, a whole lot new preparations. Especially those preparations were not frequently used in our place in Kerala, is being employed in northern parts of India to rescue people with the compensated oxygen saturation. I have seen many cases. So I have heard about, or I have been informed about such cases where the oxygen saturation was falling steadily down, and all these medicines, wonderful Ayurvedic medicines, when they are administered, the patient was wonderfully relieved, or they came back to life. Different examples are available for that. So COVID-19 and the ICU management by using Ayurvedic therapeutics have instilled a great confidence in physicians throughout India, Ayurvedic physicians throughout India, that even in ICUs, Ayurvedic medicines have got a very big role to bring the patient back to life. We have seen the employment of different types of mechanisms, that patients might have been placed in ventilators, or they might have been given high dose of steroids, or they might have been given other medicines, HCQs. Still, there was no chance of recovery. And when Ayurvedic medicines are properly instituted, especially those mentioned in such advanced cases, the patients were revived back to life. So what I am going to say that the utility of Ayurveda should not be restricted to those cases which are very moderate or mild. No, every type of Jwara is amenable to Ayurvedic medicines, and we have got a treasure trove of medicines, not simply 1 or 2 pages. It's a huge treasure of medicines are available with us, and we have to study daily how these medicines can be differentially employed for management of different diseases. So my slide contains specific contents like pneumonia, dengue, chikungunya, and influenza, and I am specifically focused, no excess focus on facts available easy for reference. I'll be stating certain facts which will be throwing light on the basic nature of these type of fevers. And then I am trying to develop a focus more on the elaboration of Ayurvedic approach. So how we can perceive these clinical entities. I will say Jwara is a huge clinical model. And these pneumonia, dengue, chikungunya, influenza, all those are single clinical entities. So, standing with that model, how we can go through the details of these clinical entities and how you can perceive an Ayurvedic approach, how you can see these clinical entities by using an Ayurvedic eye. This is what I am going to approach. This is what I am going to try to do in this presentation. So the first one I want to talk about is the dengue fever. All of you know that it is known as breakbone fever or bandy fever. There is high fever, severe pain of bones and joints, lymphadenopathy, some characteristic rash may be appearing. Benjamin Rush was the first physician who described it in 1789, mostly seen in tropical and subtropical areas of India, Africa, Southeast Asia, China, etc. Characteristic feature is common during and shortly after the rainy season. So after the Varsha Ritu, when Sharad Ritu appears, there is a chance of this particular fever to happen. This is what we derive from this data. It is endemic in India since last 2 decades. And the status of India, we've seen large outbreaks, very common in India after 2000. Typical outbreaks in Kerala, recurrently after 2003. An outbreak currently happening in Uttar Pradesh. Now reports are coming that outbreaks of dengue. A huge number of people belonging to some villages are getting admitted to the local medical colleges. And up till May 31st, 2021, we have about 6837 cases of dengue in India. So dengue fever is currently going on in many parts of northern India. The etiology is 4 distinct types of serotypes of dengue virus. So DEN denotes dengue, 1 denotes the serotype 1. So dengue 1 to dengue 4. It is a single-stranded RNA virus, belong to a group called the arbovirus group. That means arthropod-borne virus. This means that, as all of us know, these virus cannot enter directly to our body. Needs a blood-sucking arthropod to transmit it from one vertebrate host to another. There are 2 different vectors, Aedes albopictus and Aedes aegypti, which is causing this disease. These 2 mosquitoes, they are freshwater breeders, domestic surroundings, bite all times during the daytime, but they have got a tendency to bite ankles and feet at dawn and dusk. They do not fly long distances. But during the last outbreak, I think 2 years back, there was a study coming from Cochin where previously the dengue, this Aedes mosquito was seen only in the ground floor or first floor or second floor of the flats. But later, as the studies show, they are capable of flying up to 4th or 5th floor. They are enhancing their capability to fly up. So the man is considered as the best reservoir of this infection. And this disease is classified into 3, that is dengue fever, dengue shock syndrome, and dengue hemorrhagic fever. This happens in this particular way, that is bite of infected mosquito happens. Virus comes into the regional lymph nodes, replicates there. It is getting disseminated via lymphatics and blood. Viremia means when there is presence of virus in the blood. It starts within 3 to 7 days. It happens to subside in a self-limited way, and virus persists in infected mononuclear cells. This happens like this. That means the first attack of dengue may be going in a very self-limiting way. You will be getting a fever, getting naturally subsided by 3 to 7 days. but there will be persisting virus inside the mononuclear cells. When subsequent attack happens, what will happen? After the first attack of dengue, there will be every chance of a long-term specific immunity, but that may fade after many months. An infection by a different serotype may happen. When a different serotype, see the last sentence, dengue 2, den 2 followed by den 1 happens to be more serious. Somebody getting a dengue virus infection by the subtype 1 followed by an infection by subtype 2. So that results in more serious types of attacks. So that means if subsequent attack happens, that subsequent attack will be more dangerous.
Excuse me, sir, are you presenting something that's not showing? Okay.
So
Now.
Okay, can you see this?
Yeah, subsequent attacks. First attack of dengue. That's the heading now.
Now what about
subsequent attacks? Subsequent attacks.
Can you see this?
Yeah, that heading I can see.
Yeah. Now is it moving?
Yeah. How DHF and DSS turns favor.
Yeah. Please let me know if something happens in between.
Yeah.
So such subsequent attacks will be creating more serious illness. That means a normal dengue infection or dengue fever may turn into DSS, dengue shock syndrome, or DHF, dengue hemorrhagic fever, due to subsequent attacks, especially by a different serotype. So the hallmark of this subsequent attack is the increased fragility and permeability of capillaries. We have to note this point. What is the value of studying this clinical entities? This is one question. Shall we only focus into Jwara, Raktapitta, Kasa, Swasa, etc.? Natural question to a Roganidhanam specialist. My answer is, by studying the clinical entities, we can be more focused. See, the focus of DHF and DSS is towards the capillaries. So we will be more focusing towards the Rakta Dhatu or the Sira, etc. So our focus will be more on the catastrophes that is going to happen in the Rakta Dhatu, or that gives us a hint that if there is some dosha vitiation, especially to Pitta dosha, dengue fever can become fatal. So we are getting more efficient clues that can focus our medicines to specific dhatus by studying these clinical entities. That means we are sharpening our model-based knowledge by using this clinical entity knowledge. That is my perception regarding that. So the fragility and permeability of capillaries, that focuses our attention towards the Rakta Dhatu. Abnormalities in hemostasis may happen. And more than that, during this process, an antibody virus complex may form. And when this complex forms, the virus gets somehow an entry into mononuclear cells and lymphocytes and persists there. And when this reaction happens, a lot of cytokines will be pumped into blood, like TNF-alpha. And what happens is, this cytokines will lead to endothelial swelling of small blood vessels and perivascular edema will occur. See, perivascular edema. Pitta rakta kaphan vayu dushto dushtan behisira nitva ruddhagadi tai kuryuhu twang mamsa samsridam utsedham sampadam shobham. So the clinical entity of shobham, our model of shobham, is coming into forefront. That if you can recognize the presence of another model along with the Jwaram, you will be benefited by the fact that you have got another set of choices of drugs and procedures which can be taken up from the chapter of Shobham. So this endothelial swelling of small blood vessels, perivascular edema, all pointed to the presence of a Sama Shobham. In complicated cases, there will be arrest of megakaryocyte multiplication of bone marrow. Yes, the production of Rakta Dhatu is being abnormally vitiated. There is a metabolic defect in the formation of Rakta Dhatu. That is what is happening in the Samprapti or model called Raktapittam, wherein the formation of Rakta Dhatu is affected. A new entity, a deviant variety of Rakta called Rakta Pitta is formed. Thrombocytopenia happens. And hemorrhage may ensue because of thrombocytopenia, platelet dysfunction, coagulopathy, generalized abnormality of vascular endothelium leading to extensive fluid leakage in the body. So, the vascular compartment, which is very much sealed, which is very much flexible, that flexibility is being taken up by the pathological process, and that lead to the excessive spilling of the fluid component inside the vascular compartment, that leading to excessive fluid leakage. So at one area hemorrhage may happen, the other area excess fluid leakage may happen, and hence the patient may succumb. And now we have got different varieties. That is, the first time we'll be having undifferentiated fever, which may be mainly asymptomatic. Self-limiting type may present with fever, malaise, some upper respiratory symptoms and rash, and then they end as itself. No problem will happen. And then there is another set of symptoms called a classic dengue fever, where the incubation period is 3 to 8 days. There will be fever and headache, muscle pain, bone pain, joint pain, etc. That starts as mild, slowly builds up in proportion, and becomes severe in 1 to 2 days. There will be retroorbital pain. There will be lumbosacral ache. We can just remember the slogan of Kaphavada Jwara. Tabahani Aruji Parva Shiroruk, Pinasa Shosana Kasa Vibandha, Sida Jadya Timira Brahmatandra, Skleshma Vada Janita Jwaralingam. Just think of that set of symptoms which has been mentioned as the classical clinical features of a Kaphavada Jwara is being characterized in this classic dengue fever. There is occurrence of a maculopapular rash, generalized myalgia, some anorexia, nausea, vomiting may occur. Posterior cervical, inguinal, epitrochlear lymphadenopathy may happen. And all these symptoms are mentioned in this figure. Eye pain, headache, rash, muscle pain, bone pain, joint pain, nausea, vomiting. All these happens to be the features of classical dengue fever. And they say that the initial fever subsides by the 3rd day, returns back after 2 days, then lasts for 3 days. The second episode will be milder than the first one. So this pattern is just like that of a saddle which is placed on a horse. Hence it is known as saddleback fever. The hemorrhagic phenomenon, we will see that there are petechial hemorrhages, ecchymosis will happen at injection sites, epistasis and menorrhagia may happen. So when you are treating a patient with the dengue fever, even if the patient is not communicating us, it's our duty to question the patient regarding any hemorrhagic phenomenon in her body, especially if she is menstruating. We have to ask about the volume of the menstrual blood which is being passed out and whether that is having any significance with this particular disease process. This may happen during illness. And the transition phase happens slowly. How the patient is being trapped. From febrile phase to critical phase, gradual transmission occurs. Between days 4 and 7 of illness, indolent illness gradually turns fatal. The clinician's eye should be on this transition phase. So whenever you manage dengue fever, if you are properly read about this particular literature, our eye is always on the patient, whether this particular patient is entering into a transition phase where the classical dengue fever now is getting into a complicating phase. The signs of deterioration are persistent vomiting, severe abdominal pain, tender hepatomegaly, increasing hematocrit values, and development of severe thrombocytopenia. Then further changes may happen suddenly. There will be the onset of shock, rapid deterioration from 2nd to 5th day. Hemorrhagic manifestations will become severe when platelet count falls below 20,000, and that will warrant an immediate transfusion. Liver failure, myocarditis, and encephalopathy may appear. And regarding this, then we say that dengue hemorrhagic fever has started. The grade 1 dengue hemorrhagic fever is fever with easy bruising, positive tourniquet test can be seen. Grade 2, when there is spontaneous bleeding, skin or other hemorrhages, we can see. Grade 3, there will be rapid weak pulse, thready pulse. That means the volume is very less, weak pulse, but it is very rapid. Hypotension is there, narrowing of pulse pressure is there, cold clammy skin, and the patient will show restlessness. Restlessness points to Arati. Arati is one of the important signs of Dhatu. That means when Dhatu Bhagam happens, the patient will be having severe restlessness. Restlessness means they are not getting any comfort in any position. So sudden changing in patient's mood, sudden changing in demands of the patient, all those signify restlessness. And then the grade 4, there will be profound shock with the undetectable pulse or blood pressure will happen and the patient may die. So here the dengue hemorrhagic fever has slowly rapidly transitioned into dengue shock syndrome. The Lakshanas of Dhatupaga mentioned in Bhava Prakasha, that is Nidranasho, Hrudistambho, Vishtambho, Gaurava, Ariji, Aradir Balahanischa Dhadunam Paga Lakshana. Aradi is one important component. So we have to observe the patient always whether anything happens. That should point towards the onset of dengue shock syndrome. So meticulous observation of patient, continuous physical examination of the patient and recording. So every hour BP monitoring, looking for any hemorrhagic spots on the patient's body, questioning the patient, also looking into the patient's shift in attitude and pattern, any evolution of the symptoms like restlessness. All these will point to the rapid deterioration and succumbing of the patient. So we have to act fast. And DSS happens to be the most serious complication of dengue fever. As I have told previously, restlessness, abdominal pain, shock, rapid diaphoresis, clammy skin, circumoral cyanosis, change in mental status. See, circumoral cyanosis, a sign of sudden onset, reduced oxygen saturation, rapid diaphoresis happening, narrowing of pulse pressure, hypotension. All those point to the onset of shock in a dengue patient. And usually investigations doing not at the time of this dengue shock, instead prior when the patient is getting admitted, blood routine that may show leukopenia and neutropenia, thrombocytopenia, leukopenia or neutropenia, very common in any viral infections. Chest X-ray may show some pleural effusion because of rapid leakage happening in the endothelium. Urea creatinine may elevate in complications. There will be attending renal damage. So Shobha Samprapti ensuing, renal damage is happening, Raktapittam is happening. All these should be kept in mind when you do investigation. And the classical diagnosis is by doing dengue NS1 antigen by using ELISA for specifying this is dengue fever. The prior investigations like the blood routine will support or will inform you about the deterioration happening in the patient. And dengue IgM antibodies is also available for correct specific diagnosis. And regarding Ayurvedic approach, I may say the dengue fever start as a Vada Kapha Jwara or a Vada Kapha Pradhana Sannipada Jwara. It may proceed as such and end. It can happen like that in the undifferentiated fever pattern or in the initial phase of dengue fever. May have a flare-up of Pitta or the patient may be a Pitta Prakriti patient, and there is every chance of this Jwara turning into Tridosha Pradhana Sannipada. Leads to specific dushti of Raktavahasrodas. The Raktavahasrodo dushti or Pitta Pragoba might be triggered during the initial attack. Also, that should be borne in mind. A patient who is having a past history of dengue fever, even after fever is continuing those food items or those pattern of life that is triggering the Pitta dosha. So that harbors a Pitta Sanjaya in his body, and when again dengue infection happens, that Pitta Sanjaya will get into Pragoba. That will lead the Samprapti. So, the presence of a Pitta Prakopa or Pitta Sanjaya has to be taken into consideration. The patient might have used Pitta Dushti Nidanam in between attacks. So, the circulation of Samadosha and Agni, which specifically resides in Rakta Dhatu in this case. So, when it resides in Rakta Dhatu, what happens? There will be a leakage, endothelial leakage. There will be one branch is proceeding towards Shobham. Dosha Bhaga is not happening. Rapid